Good afternoon, and welcome to the 2016 Robert S. Gordon Jr. Lecture in Epidemiology. My name is David Murray. I'm the NIH Associate Director for Prevention and the Director of the Office of Disease Prevention. I'm pleased to represent Dr. Collins today and introduce our speaker. Dr. Collins intended to be here but was called to a meeting by the Secretary, and I understand he has to go to those when she phones. The Robert S. Gordon Lecture is awarded each year to a scientist who has made major contributions to research or training in the field of epidemiology or the conduct of clinical trials. The Gordon Lecture Award recipient is selected based on the recommendation of the NIH Epidemiology and Clinical Trials Interest Group. This is the 22nd year that the Office of Disease Prevention has sponsored the Gordon Lecture Award. The list of prominent scientists who have previously received this award can be found in our office's website, prevention.nih.gov. The Gordon Lecture Award was established as a tribute to Robert S. Gordon Jr. for his dedication to the field of epidemiology and clinical trials and for his distinguished service at NIH. Over the course of 30 years, Dr. Gordon served in numerous senior leadership positions, including Special Assistant to the Director and Chief Advisor for Clinical Practice and Research. He was an early organizer of efforts to address the emerging problem of HIV and AIDS and became a key coordinator of AIDS research on the campus. For the last 10 years, Dr. Gordon made important contributions to policy and management issues regarding epidemiology, clinical trials, and health effects of environmental hazards. Professor Bracken is the Susan Dwight Bliss Professor of Epidemiology, Professor of Obstetrics and Gynecology, Reproductive Science and Neurology. He's former head of chronic disease epidemiology and former vice chairman of the Yale School of Public Health. He has studied and taught at Yale for the last 48 years. Professor Bracken has published some 380 articles in the peer-reviewed literature, authored 3 important books. The second, Effective Care of the Newborn Infant, introduced the concepts of meta-analysis to neonatology in 2006 and was named by the British Medical Journal as one of the most influential books in evidence-based medicine and was instrumental in assisting the foundation of the International Cochrane Collaboration. Professor Bracken was the founding director of the Yale Perinatal Epidemiology Unit and co-director of its successor, the Yale Center for Perinatal, Pediatric, and Environmental Epidemiology. He's taught courses in evidence-based medicine and healthcare, pharmacoepidemiology, perinatal epidemiology, and general epi at Yale for many years. He's directed numerous epidemiological investigations, almost all of which were funded by NIH. He's served on many study sections and committees for us, including the Council of the National Institute of Deafness and Communications Disorders. He chaired the first Congress of Epidemiology in 2001 and the first International Colloquium on Genome-Wide Association Studies in 2006. He consults for many international corporations and agencies, including the World Health Organization. He has served as the elected president for 2 major epidemiological associations, both the American College of Epidemiology and the Society for Epidemiologic Research. He is the 2013 recipient of the Lilienfeld Award from the American College of Epidemiology and a 2015 honorary doctorate from the University of Gloucester in the UK for services to medicine. His presentation today is entitled Inefficiency and Waste in Biomedical Research. How prevalent is it? What are its causes? How is it prevented? I'm particularly interested in that last aspect. There will be time for questions after his presentation, and I would also like to invite everyone who's here today to join me at the reception for Professor Bracken at the NIH Library just off to the left after the presentation is over. Now please join me in welcoming the 2016 Robert S. Gordon Lecture Award recipient, Professor Michael Bracken.
Thank you, Dr. Murray. Looking at the list of previous awardees, I realized that I knew most of them. I admired all of them, and it's a real privilege to join that group. I think I knew Dr. Gordon. When I saw his photograph, it sort of rang distant memories. I wish I'd known him. It turns out that we had a couple of common interests. He sang in a choral group, and he enjoyed boating, both of which are things I enjoy. So it's also nice to be linked to Dr. Gordon. Let me just show you my disclosure statement. So this was the first paper to directly confront the issue of waste in biomedical research. Ian Chalmers and Paul Glazier, they're important figures on this, in this topic, and so you'll be hearing more about them. And they talked about 85% loss in the way we do our medical research. So how do they arrive at 85%? Well, 50% of registered trials are never published in full. 50% of published research has significant flaws, making it unreliable. 50% of published research ignores existing studies, is not based on systematic review, may be redundant, and may be unnecessary. So that sort of gets you down to 12.5%, which they rounded up. And we'll be talking about all of this in more detail. But I want to argue that 85% may in fact be conservative, and I also want to argue that waste is more than just waste of money, waste of resources. It actually can be harmful to the public's health. And I'll give you, I think, several examples of that. This is the first of 5 papers which are sort of pivotal for today's talk. I'm going to focus on research design, conduct, and analysis. These 5 were published together in the Lancet in January of 2014. And just to tell you what I am not going to be talking about, I'm not going to be talking about the increased burdens from government regulation on research. I'm not going to be talking about increasingly burdensome IRB regulations that can both delay research startup while the grant money is being spent, and they can reduce subject participation. And I'm not going to be talking about a misguided focus in academia on, let's call them first reports of findings rather than on reliable replication. These are the authors of the Lancet papers. Chalmers and Glazier were the sort of conductors of the orchestra here. And I have to say that the opinions of this talk are not necessarily those of all of these authors. Some might disagree with them. I suspect 1 or 2 would. So I've got 4 parts to my talk. The first is hurricane warning, early warning signs that in fact we had a problem. I want to go to that evidence. Maneuvering with difficulty, what other evidence was the Lancet papers based on? Thirdly, we'll be looking at more recent developments and actually seeing very little evidence of improvement. And fourthly, some solutions in design, conduct, and analysis. And usually at NIH, there are people with uniforms in the audience who should be very familiar with these signal flags, but I don't see any today. So first, early warnings that we had a problem. This is a paper by John Ioannidis, who is another influential researcher in this area. And he looked at a range of SNPs for various diseases. They were either protective or they were at risk. And on the left-hand side are the first studies, and usually based on limited evidence. And then as you track for all of these over time, the larger, perhaps more reliable studies being done, the effect estimates all attenuate towards 1. And this is a trend that you'll see repeated many times as we go through this. In science, the winner's curse, of course, is to do with an auction. If you win something in an auction, you just bought something that nobody else in the world thinks is that valuable. In science, you publish first, but it's likely to be an exaggerated or a wrong result. And poorly designed studies have the largest effects. That's one of the common themes. This is looking at a similar thing for randomized trials. 85,000 forest plots were studied in a text search. Only just under 10% had odds ratios more than 5 in the first published study. And they were generally found in small trials. And when the studies were replicated in 98% of the large effects actually became smaller in the later trials. So it's a very similar trend in the evidence that we saw from the genetic studies. Something else that was going on in an early warning was realizing that p less than 0.05 does not mean there's less than a 5% chance of that the null is true. And if we think about studying 1,000 associations, normally when we do this, we expect 50% of the underlying hypothesis, 50% will be true, 50% will not. But of course we know that's not right. I mean, most of the things that we study in epidemiology turn out not to be risk factors for the disease that we're interested in. So here we're assuming actually only 10% are likely to be true. We also know in most of our studies they're underpowered. So here we're assuming there's 50% power rather than the usual 80%. And when you do these calculations, you actually find that the type 2 error rate is down here, is almost 50%. That's the chance of finding a false result. And if we actually change this and think that actually maybe only 1 in 100 of the associations that we study will actually be correct, then the false alarm rate, as it's called here, is about 91%. So a very high chance of finding making false decisions about the research. And this paper is also a very famous paper, again by Ioannidis, and using a similar sort of calculation, he looked at the predictive value from research, and here's one in adequately powered trials. The predictive value of a trial actually being right, even though it's showing statistical significance, is 85%. And in epidemiology, adequately powered here, 20%. And if, of course, you change the power, that predictive value goes down. And all of that refers to looking at a single association. And if we think about multiple comparisons, and in epidemiology nowadays, it's very easy for a paper to be looking at 50 associations, 100 associations. We see papers that are looking at several hundred associations. And if we start to worry about multiple comparisons, here 40 comparisons, actually a chance of a false positive rate is 90%, and so on. So the risk of being misled in modern epidemiology, modern biomedical research, is very high. So that's another background theme. Here's another one, and this is again a very influential paper. This is looking at comparing protocols from ethics committees, looking at the primary and secondary outcomes, and then comparing them to the published work. And what Chan found was 50% of efficacy outcomes in protocols and 65% of harm outcomes were incompletely reported. And it was more than that, it was biased. The statistically significant outcomes being 2.4 times more likely to be reported than non-significant. And for the harm outcomes, 4.7 times. And interestingly, actually, 6% of authors denied the existence of unreported outcomes despite evidence to the contrary. And this is some of the just examples of what he was looking at. A pre-specified primary outcome, event-free survival rate, omitted from the published report. Outcome, overall symptom score changed from a secondary outcome to a primary outcome, and primary outcome, percentage of patients with graft occlusion, listed as a new primary outcome and not even mentioned in the protocol. And of course, you can guess why these changes are being made, and more about that in a minute. As we focused on protocols, it's become clear that the protocols themselves are deficient, and in this particular paper, 25% of protocols actually didn't mention the primary outcome, 59% didn't mention allocation concealment, a third didn't mention blinding, and so on. So we've made great strides towards protocol registration for trials, but the quality of the protocols is still lacking. And these are protocols from IRBs and science committees. Now, I mentioned half research is unpublished. This is some of the evidence. It goes across all countries and hasn't changed much over time. This is another study, and this is looking at countries again, but down here we've got size of trials. Again, less than half are being published. This is looking at class of trial. So phase 4 being published a bit more than phase 1 or 2, but still only about half being published. And this will be academia publishing just over half, industry publishing 40% of their trials. This looks at publication over time, and you can see after about 5 years, then in this analysis, some 60% are being published, and then it just levels off. They don't get published. So this is trials. This is registered trials. What would the evidence look like for observational data? Well, we don't really know because we don't register observational studies. But we can be almost certain that it would be worse. This is an influential study from Kay Dickerson. This looked at protocols from Hopkins, NIH, and so on. And again, looked at publication and why they were published. And you can see what you would have suspected, I think. It's the significant findings that tend to be published more than the non-significant. External funding also tends to drive publication. So we've got biased reporting, we've got biased studies. This is why we are worried about what is basically publication bias. We'll beat up on Nature a little bit here. It's only fairly recently that we've understood that entire bodies of literature can be biased. It's not just bias in single studies. So negative results often not published, maybe 26 studies performed here, and actually that's what we're looking at. So we're always looking at limited and restricted bodies of evidence, and what's worse, biased bodies of evidence. So another theme that's been going on in the last 25 years is how observational studies and the results from them are being so frequently overturned by trials. So the examples here are from the Women's Initiative trials. Despite many observational studies suggesting benefit from calcium, it wasn't found in the trials. Low-fat diet, no reduction in risk of colorectal cancer, no significant reduction in invasive breast cancer from the trials compared to the observational studies. This is a Cochrane systematic review looking at typically a 25% reduction in homocysteine. The outcome is cardiovascular disease, and the trials here suggesting no effect. But if we look at what the observational studies had found, this is a meta-analysis of them, the typical odds ratio was a reduction of 27%, significant. The prospective studies also showing protective effects, and the retrospective studies, and this is typical again, an even stronger protective effect, highly significant. But that is contradicted again by the trials. So why are so many studies here actually wrong? And this is perhaps the most famous example of all. We had the nurses' health cohort suggesting reduction in cardiovascular disease, strong effect, and yet the trial going in the opposite direction. And I know there's been a lot of work trying to suggest that it's different hormones, different age groups, trying to reconcile these. But I have to tell you, for me, I think the difference is residual confounding in the nurses study, which, despite the large size of it, it simply could not be adequately controlled. And we have to remember something here, that the large observational studies do not actually reduce bias. The bias is still there. In fact, it may be amplified in large studies because of the increased power. So there are lots of issues to do with bias, and we'll talk about this again. But the epidemiology community had to deal with this. It caused a lot of angst in the in epidemiology departments all across the country. I actually thought Gary Taubes did us a good service in pointing out some of the problems that we had in conducting epidemiology. And then we also had this, which every epidemiologist is aware of. It's probably part of their slide kit. Today's cough is causing depression in twins. At least it's not in men over 70. So another theme, moving on, is this. This was a paper in the New England Journal, 1992, looking at IV streptokinase for myocardial infarction. And this is a cumulative meta-analysis. So just for those of you who don't know, every time a study gets entered into this, the effect estimate reflects the studies that came in before. So that's actually the point estimate there. That's based on 2 trials. That's the estimate based on 3 trials. That's the estimate based on 4 trials, and so on. So this is showing many years of research looking at this question, and they're all trials. And what you see is necessary replication in the early trials being done, and then at some point wasteful duplication. Because these trials, and they include some very big ones, ISIS-2 is down here, at this point you need an incredible amount of evidence to switch an estimate from being so protective to either being neutral or going on the other side. So this is a technique for looking at the evidence as it is accumulating, and many of these are actually done retrospectively. If they'd been done in a prospective way, which I'll be talking about later on, then maybe some of this would not have been wasted duplication. This is a similar plot for tranexamic acid used in surgery on the risk of blood transfusion, and again showing they're all trials showing here there's a very strong evidence for benefit, and surely these are wasteful duplication. The evidence was in early on this particular question. And this is another famous series of trials looking at antenatal steroids and neonatal death. First trial done by Liggins in New Zealand, 1972, shows a significant protective effect, and it actually never disappears. It's always the same estimate. All that happens here is the confidence intervals get a little tighter. Wasteful duplication. And of course, wasteful duplication also means patients being submitted to placebos when they could have been on active therapy. Now again to another theme, looking at the animal research and the need for systematic reviews. This analysis found that much research into potential treatments is wasted because the research is poorly conducted. We'll see that all of the problems that are being discussed in the context of human studies are even greater in the animal research. It's important for many reasons. Human studies obviously depend at some point on the animal work before you do the first in human work. They're all based on animal studies. And then we've got the issue of animal welfare. There's never any justification for the use of animals in badly designed experiments. And there's never any justification for the use of humans in badly designed experiments either. So just to remind you of some of the issues in animal experiments, that different species and strains, different metabolic pathways, metabolites are different, different models for inducing injury and illness, and that can vary very differently from the human condition, variations in drug dosing schedules and the regimen for drug use, variability in how animals are selected, is it randomized, choice of comparison therapies may vary, loss of follow-up may vary, small experimental groups with inadequate power, simplistic analysis doesn't account for confounding, and failure to follow intent to treat principles, one of the cornerstones of human trials, is universally ignored in animal research. Nuances in lab technique that might influence results, methods of blinding investigators, if that ever happens, selection of a variety of outcome measures, maybe surrogates or precursors of uncertain relevance to the human condition, and length of follow-up that may not correspond to disease latency. This is an example of TPA in stroke. Everything to the left of the zero is showing a protective effect. So this is again a cumulative meta-analysis. You can see here again the early research showing much stronger protective effects than the later work. But here again we've got necessary replication and we've got wasteful duplication in the animal work. And in this particular example, after about 1,500 animals have been tested, you were down here, and yet another 3,700 and odd animals went through testing. So this was a retrospective, cumulative meta-analysis, but if people had actually been tracking this in real time, then surely these experiments would not have been done because they were not necessary. This is just looking at the number of systematic reviews, which I'll be talking about more in a minute. In human studies, it's 408 per 10,000 publications. In animal studies, 80. So 5 times more systematic reviews being done in the human work than in the animal work. And I think many of us would argue that this is, even in humans, this is far too small a proportion of systematic reviews being done in relation to all of the whole body of work. So whatever evidence was the Lancet paper based on, and this is what I'm actually talking about, but this area is low priority questions being addressed, important outcomes not being assessed, and patients and their clinicians not necessarily being involved in research agendas. So for example, arthritis studies where when they did surveys of patients, they were actually more interested in questions about fatigue than they were about pain reduction. So that's the overall framework. This is looking at publications and the quality of them, and these are all the percents missing important information, and it's hard to see this, but 49% refers to not mentioning any adverse effects in the abstract, 40 to 89% inadequate treatment descriptions. I mean, all the things you would be looking for in a publication to explain the methodology, large percentages missing when you do this kind of analysis. And redundant epidemiological research. This is looking at the question of baby's sleeping position to protect against SIDS, front versus non-front, and looking at, again, a cumulative meta-analysis. And you can see here, again, necessary replication and wasteful duplication. The increased risk from front sleeping position, evident almost from the beginning of this series, and clearly evident down here. And this particular analysis, the author suggested if they'd actually recognized the importance of not sleeping, putting babies on their front, then it might have prevented 10,000 infant deaths in the UK and 50,000 in Europe, USA, and Australia. So this argues again for what is not just only research waste, but it's also harmful to the public's health. So let me just go back to what an animal systematic review would look like. I've just told you that these are actually quite rare. This happens to be looking at a stroke drug. And these reviewers created a 10-point scale to try and give some quality assessment to the animal experiments. Only 1, blinded therapy. 2, blinded assessment. Actually, 3 of these studies got 0 points on this quality scale, and the maximum score was 7. And this is a very typical result from going into a body of literature from the animal research and trying to assess the quality of the studies. And we also see this. When you rank the quality of the studies, and these remember they're the worst, this is the best, against the effect sizes, the worse, lower quality studies producing the larger effect sizes. And we see that time and time again in doing these kinds of analysis. This is looking at trends over time. The blue is randomization, and you can see an improvement in the more recent studies after 2006, but still it's less than a third of these studies are being randomized. Now I want to talk about bias. 235 biases were identified in 70 million PubMed papers. This is quite an active bit of research in its own right. I always thought there were only about 50. But I want to just show you how one bias can actually, I'm picking 3 just as examples, can have a significant effect. So that's recall bias. We're going to look at that. And this is, I would say, an infamous meta-analysis of asking the question, if a woman has a prior induced abortion, does that increase her risk for breast cancer? This meta-analysis is actually still being used in some state houses to limit reproductive choice. But this is what a Danish study found, they were all case control studies, they actually did record linkage. And 1.5 million women linked between induced abortion and breast cancer, relative risk of 1. So what happened here? Why was this inflated risk? Well, you've got to think about how you do these studies. You're asking women with breast cancer about their previous pregnancy history, and they're likely to tell you everything. And then you're asking often a healthy control group of women about their pregnancy history, and they might not tell you all about their previous induced abortions. So you get the inflated risk in the cases. Some people did this correctly. Dr. Brinton from NCI did a wonderful case control study, absolutely nailed it there. But look at some of these results. These are wildly high risk estimates, even one protective effect there. So that's how one bias can function and influence a body of literature. Here's interviewer bias. And this is a meta-analysis looking at the question, does residential EMF increase risk for childhood leukemia? We've got the studies here, the high-quality studies suggesting no substantial increased risk. The lower quality studies down here suggesting increased risk. And the first study in this whole body of literature was this one, Wertheimer and Leeper. This is a study that closed schools in California. And the interviewer bias comes in because these studies were done looking at wire coding, the thickness of electric power lines into the house, how close to the house were transformers. And these were all estimated by interviewers who in this study knew if the house was a home of a child with leukemia or was a house of a control group. And so whereas these studies tried to manage that sort of bias, this early study, which had a big effect in terms of creating a major public health scare, didn't manage to do that. And the third example I want to use is channeling bias. Channeling is a form of bias by indication, and bias by indication in pharmacoepidemiology, of course, is the drug that you're worried about causing the outcome that you're interested in, or is it actually the disease that the drug is being used to treat? So this is looking at the question of congenital cardiac defects after the use of specific antidepressants. Hybrex, who had a big Medicaid of almost 1 million women database, actually tried to look at the effect of potential for confounding from the underlying depression and from associated factors associated with being depressed. These are some of those factors, and these are the 3 SSRIs that were studied. So higher rates of smoking, about 2.5 times, 2.5 times the rate of being diabetic, and about 2.5 times the rate of using other suspected teratogens. So that's the confounding. And this is the unadjusted analysis, and we see increased risks here, and this is typical of a whole series of studies that were done that were not able to control for indication by bias. But in this analysis, they first of all did an analysis in the depressed women group, and you can see those estimates have moved towards unity. And then they also controlled for 200, actually, in a propensity score, potential confounders. And you can see they've even moved closer to unity. That's where they started out. So another example where, unless you're very careful, you can be misled by the observational studies. So what about recent changes? So this is a paper that came out in Science at the end of last year, looking at psychological sciences, and they tried to replicate studies. This is that line there would be the replication. 83% showed stronger effects in the original study, and the effect size in the replicate was half that in the original studies. So another example of the things that we've been talking about here. And here were actually replicates that went in the opposite direction. Of course, in the original, almost all were meeting the 0.05 level. In the replicate, only 36% did. And this is interesting. We expect when we do replications, 95% of the effect estimate will be within the confidence intervals of the original study. Here it was only 41%. So it's actually not just a simple failure to replicate, it's actually gross failure to replicate. As you might expect, this has been challenged by some of by people in psychology. That's a number they came up, and it's being pushed back again by the original authors. 83% of replications had smaller effect size. It's kind of close to that 85% we talked about right at the beginning. In the animal world, it continues to be poorly designed. This cover that they did of our paper was quite interesting. You see down here all the rats, and here we are. And it's a long distance from there to there, isn't it? And that's obviously part of the problem. But it's one of the problems why it's so hard to predict to humans from rodent models. What's wrong? Well, there aren't enough systematic reviews of animal studies. I've shown you that. Many studies are poorly designed and performed. I've shown you that. They're not adequately reported. And I think this is a state of play that we observed in human studies about 40 years ago. And it's going to take time to catch up. This is looking at trials in 1,286 trials in 205 Cochrane reviews, using the Cochrane risk of bias tool. Only 16% met low risk of bias, 41% unclear, high risk 43. So 16% you could clearly say were low risk. And these are the sources of bias. This is actually sequence generation, allocation, concealment, randomization, blinding of participants, that's what we call performance bias, 58% there at high risk. And these are blinding of the outcome assessment and incomplete outcome data or attrition bias. So still high rates of bias. What these authors did was then try and look for how they might adjust these studies to reduce the risk of bias, and found that actually with almost very little cost, very little effort, you could reduce some of these biases by 50%. So it's not an issue of cost, and it's not an issue of sort of ease of doing it. It's actually an issue of knowing that it should be done. And this is from Ben Goldacre's website in the UK. He's continued to look at what the protocol says in trials, what the outcomes say. He looked at 67 trials, 9 reported perfectly compared to the protocol, 300 outcomes not reported, 357 new outcomes silently added. So still continuing problems here. He actually went on and sent letters to the 58 journals pointing out the fact that these publications were differed from their protocols, and only 7 have been published so far. And a meta-analysis, again, looking at the median discrepancy between protocol and outcome reporting. 31% of trials had a discrepancy. I guarantee you in observational epidemiology, that would be much higher. So some solutions for trying to improve the situation. I want to talk, the first is to reduce the play of chance. I think the play of chance can produce erroneous results. We, of course, always worry about it, but I think that we've greatly underestimated how this can work. This is the most famous, the most cited after-dinner speech in science history, Bradford Hill. He asked for perfectly clear-cut and beyond what we would care to attribute to the play of chance before actually moving on and doing his causality analysis. And clearly, we're not doing this. Recall how liberal a p-value 0.05 is. So in my recent book, I've actually suggested that sigma 2, which is our usual alpha, should be changed. We should be actually looking at 0.01 or even 0.05, because we are spending so much time and resource following false leads. And a beta, I think, should always be 0.1. 0.2 is too liberal. And this contradicts, of course, popular epidemiology teaching, which tends to go in the other direction of let's sort of not worry about the p-value. But I think that has led us to some really harmful findings, as I've discussed earlier. And I can't think of a single important risk factor that would have been missed by using more stringent p-values, that there are a great many false positive findings that we could have done without. So get rid of that. The American Statistical Association just last month almost talked about the use of this 0.05 level leading to distortion of a scientific process. And I think the discussion should be made about the 0.1 level, not the 0.5. And this is from, again, JAMA last month. They looked at 4.6 million p-values in 1.6 million Medline abstracts. Again, one of these text mining exercises, but concluded more stringent p-value thresholds are probably warranted across scientific fields. The 0.5 in almost all abstracts suggests that this threshold has lost its discriminating ability for separating false from true hypotheses. And just to go back to Bradford Hill, you should remember when Bradford Hill was actually writing and doing his work, people in one paper usually studied one hypothesis. Does smoking increase risk for lung cancer? They didn't have the computing capacity to study 200 associations in one paper like we do. So no, it's a different world. And again, from the American Statistical Association, it's important to know how many and which analyses were conducted and how they were selected for reporting. So again, now paying more attention to multiple comparisons, which epidemiologists always comment on in their discussion sections, but rarely correct for. So that, of course, we often use Bonferroni in genetics. Bonferroni is still frequently used. I know there's false discovery rates and different methods. Bonferroni is quite simply that. And if people knew the citation to Bonferroni, it would probably be the most cited paper in the biomedical literature. Actually, that's the reference to Bonferroni, and it is very obscure. So it's probably why it's not actually cited. But Bonferroni is quoted a lot. The issue of larger, better-powered trials is not new. It's proposed by Richard Peto. He was a 2002 Gordon Awardee, by the way. That's him on the left. It's Richard Dull sitting down there. And Peto was suggesting if one's trying to decide how billions of future patients should be treated, it may be appropriate to randomize at least many thousands or even tens of thousands. And just to remind you, this is what simple large trials are all about. Avoid random error with large numbers, detect small or moderate but important effects, use more important clinical outcomes, randomize in an easy way using the uncertainty principle, simplify data collection, analyze intent to treat. Bias, how do we reduce bias? Well, the protocol registration has gained absolutely no traction in epidemiology, widely used in trials, actually required now in trials by journals, by the Institute. It's been vehemently opposed in epidemiology that protocol registration should occur. We've argued that if PhD students have to record a protocol, why not the rest of us? And of course, the same imperatives for registering trial protocols apply to observational epidemiology. So this is still a work in progress. There are numerous guidelines being produced, PRISMA for meta-analysis guidelines, SPIRIT for protocols, STROBE for observational studies, CONSORT for trials. And this is all very helpful. We even have now animal guideline trials. And these are all actually for reporting guidelines. But of course, if you know how you're expected to report studies, then that should improve study design and conduct. And the NIH has jumped in, and they've got plans to enhance reproducibility. And the bits I picked out from this paper, improve training and experimental design, all meant to that. Improve data transparency, that of course is to do with making data sets available for wide use. And systematic evaluation of grant applications to look at the scientific premise. And I just want to expand on that a little bit, the scientific premise. So this has got to do with using systematic reviews of extant evidence in the protocol. And this is actually looking at a citation analysis on grant applications. These are the studies that do not support the hypothesis for the grant application. It managed to get one site. These are the studies that do support the application, and of course they got heavily cited. So this is using a non-systematic method of looking at evidence in a protocol. And this occurs even when research from the same laboratory is being cited. They somehow don't mention their studies that were not successful. This is came from a protocol for the CRASH trial. The CRASH trial was looking at use of steroids for head injury. And these are the trials that had been done up until that point. That's the risk estimate. But if you look at the numbers in these trials, the denominators, 5, 12, 50, 80, 81. I mean, this is a body of evidence that is not going to give you the answer you want. So this is actually many years, 23 years of wasted research. The CRASH, and I'll come back to the CRASH trial in a second, but this is how you would like to see evidence presented in a protocol, but it's the extant evidence that you're now going to go and test further. So systematically then updating all of the evidence after study completion, Chalmers again and Michael Clark discuss this as islands in search of continents. This is putting your finding from your research back into the body of evidence. Misquoting John Donne here, but that's okay. Islands in search of continents. They looked at 26 trials. One was the first trial on the question, so there's obviously nothing to integrate, but only 2 of the 25 trials actually put their results back into an updated systematic review. And they updated this finding more recently. 106 trials looked at, 12 were first trials, but again, only 3 of the 94 that are left integrated their results into a systematic review. The CRASH trial, when it finished, was a large, simple trial. It actually meant to randomize 20,000. It stopped after 10,000 because of the result. This is the CRASH trial here. So that's what we just looked at. And when you actually redo the meta-analysis with their result, then you get a clear evidence, 18% increased risk of mortality in patients treated with the steroids. And then the overall review now taking all the evidence into account, 12% increased risk. So that's an island finding its continent. And I want to just finish with this. This is actually the first sentence in the first paper, in the first issue of the New England Journal in 1812. And that's what it says. It's easy to read. In our inquiries into any particular subject of medicine, our labors will generally be shortened and directed to their proper objectives by a knowledge of preceding discoveries. So they're not asking about systematic reviews. They didn't know about that. But they are, even back then, asking for a proper reintegration of your research findings into the entire body of knowledge. So just to summarize, to reduce the play of chance by designing studies with more stringent alpha and beta values, using much larger studies, pay more attention to threats from multiple comparisons, strive harder to reduce bias. It subverts all our research, and try and comply with these standards and guidelines. Journals need to do this. We have evidence that journals who are supposed to be asking authors to comply with the consort trial guidelines are not doing so. Systematically review the extant evidence in a published protocol before starting new research. This is something NIH could actually insist on. MRC has already. Follow the protocol outcomes when reporting findings, or declare in the paper the differences, why you've gone to a different outcome, and systematically update new findings in the context of all available research. So here's Robert Gordon. And I know he had many epidemiological interests, an administrative post at NIH, and I am confident he would have supported the need to stopping waste. Thank you. Yes, please.
Just 2 comments with respect to animal models becoming useless. Now, there are several companies now printing 3D versions of human cells that could be used at least in terms of acute drug reactions and things. It might eliminate the use of animals. And I guess that's... in terms of your comments before, you were referring to the multiple comparison problem, which is prevalent in a lot of studies, and I think it's kind of unavoidable, because when people first start doing something, there's no doubt they're going to make a modification. And when they make a modification, in fact, what they're really doing is just designing a new study, but most people don't have the realization that things have to be as to the original protocol. But it doesn't sound possible in some of these more complicated studies to actually go through without making some changes as to primary or secondary endpoints or modifications. So I think by definition, you're never really going to reach perfection, no?
Right. So the point about your second point is to be transparent. I mean, as a reader of a research paper, I think you'd like to know about those modifications, and unfortunately, that is often not what happens. What was the first point?
And the other thing is, in terms of p-values, there's some journals not at the level of Nature or Science that have abolished psychological journals, and I forgot which one it is, but it's abolished the use of p-values in smaller studies and saying that they will only now accept descriptive studies because they found that the p-values were misleading. In smaller studies, it's a less significant journal of psychology or psychiatry or something. I know that they made a comment on it in Nature.
Right. So, you know, there are, I don't know, what, 3,000 journals, 4,000 journals? It seems to be more and more every week. But there are a handful, not many, that have suggested you shouldn't use p-values. You should use just the confidence interval. And, of course, people then use the confidence interval and interpret it as if it was a p-value. But there is still broad use of p-values by the FDA, by leading journals. And I think the issue I'm making is I think the p-values are actually too liberal in the way we do our research nowadays. But unfortunately, they get translated as being, they're given more importance than they really deserve, just because they meet the 0.5 threshold.
Yes, and certain specialties such as pathology or forensic pathology, by their very nature, are not going to be able to provide the type of quality in terms of studies because they don't have a clinical element. So I guess not many of them are going to go to Nature or Science, but I'm just making the point that not every specialty is going to be equipped to conform to these types of standards.
Yeah, okay.
There's another person who has a question. I better let him.
Thank you.
Yeah, hi, Mike Lauer from the Office of Extramural Research. That was a fantastic talk, and I want to thank you for and congratulate you for getting this award and for coming to talk with us today. So we're, as you mentioned, NIH is now trying to address this head on, and we have changed some of the requirements for our applications, and we are also changing our review criteria. And one of the things that we are seeing is that the response of the community is decidedly mixed. Some people think that this is wonderful, we're moving in the right direction, and other folks are getting very defensive and are saying, why is our area of science, and you can just name the area of science, why is our area of science under attack? And this is yet again another example of the government piling more and more regulations upon us and trying to micromanage us and trying to tell us how to do our research, and we investigators know how to do best, and why don't you just leave us alone and let us be creative? So help us.
Yeah, well, it doesn't have to be government regulation. In fact, in Europe now, there's a lot of emphasis in trying to train people doing animal work in good methodology. You know, the Medical Research Council has shown great interest in this. There's a strong push from academia and people who actually work in these areas to up the quality of the studies. So I'm not personally in favor of government regulation either. But I think it should be self-evident to people in academia that they need to clean up their act. And it's not to say, and I hope I've not left the impression that everything in human research is all fine, because it's not. I mean, we certainly have our problems, and I think I've given you some examples. But I think the low-hanging fruit here in the biomedical world is to try and tackle the folks doing the animal work and at least bring them more up to speed in what you expect in doing these studies.
I'll ask a question. Mike just referred to changes in the rules, asking people to pay more attention to methods, for example, to paying more attention to reviewing what had been done previously. My concern is that if there aren't changes to the way that the applications are reviewed, in terms of what the reviewers do, there's no enforcement of those new requirements. And I just wonder what your thoughts are about that.
Well, study sections are perhaps the most powerful group, if you think of the whole process of how we apply for money and get it and do the research, I mean, they're really the gatekeepers for changing behavior. And if study sections start to impose tougher methodological criteria on the research that they're reviewing, the word will get back very quickly to investigators in academia that they need to pay more attention to this. And I think that perhaps the societies would help with this, and even within the university, you might find epidemiologists who are actually happy to go and talk to the people doing the animal work, and that happens in my place. It happens in some other places. But I think the way study sections function could have a large effect in improving things.